हे जे
मॅडम
यवतमाळ ना
ऐकू येते.
मॅडम आम्हाला पूर्ण ऐकू येते त्यांची प्रेमकथा.
गुड मॉर्निंग वृषाली, गिरीश
Good
सर.
morning. Good morning, Gayatri madam. Lata madam, good morning. Isha, I think we should go live. We can go live now. We are, I mean, it's already 32.
We are live now, sir.
Okay, so good morning, ladies and gentlemen. Myself, Dr. Girish Mane, Chairperson of Adolescent Health Committee, Fogsi. And based on coordinator of Adolescent Health Committee, Dr. Supriya Arwali, who is even committee chair of this Adolescent Health Committee of Amogs. Both of us, we are doing this CME along with Yavatmal Obgy Society, Obgy Society, and Obgy Society. I welcome all of you. Welcome all the faculties, all the chairpersons, all the delegates on this year. So may I request now Dr. Vishali, may I request Isha to play the video of prayer, please?
इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना। इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना। हम चले नेक रास्ते पे, हमसे भूल कर भी कोई भूल होना। इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना। हम चले नेक रास्ते पे, हमसे भूल कर भी कोई भूल होना। इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना। दूर अज्ञान के हों अंधेरे, तू हमें ज्ञान की रोशनी दे। हर बुराई से बचते रहे हम, जितनी भी दे भली जिंदगी दे। बैर होना किसी का किसी से, भावना मन में बदले की होना। हम चले नेक रास्ते पे, हमसे भूल कर भी कोई भूल होना। इतनी शक्ति हमें देना दाता, मन का विश्वास कमजोर होना।
Thank you very much, Anisha. Now may I request Dr. Vishali Mane, President of IOGS, for her presidential address.
Thank you, Girish, Dr. Girish Mane. Good morning, all respected faculties, delegates, and dear friends. It's gratifying to look around and see so many familiar and respectable faces. I, Dr. Brishali Mane, President Yavatmal Obgy Society, welcome you all for this CME dedicated on adolescent health. I'm thankful to Chairperson, Adolescent Health Committee Fogsi, Dr. Girish Mane, and Amogs Chairperson, Dr. Supriya Arvari, for their cooperation and guidance. Adolescent health has been a subject very close to my heart. Me and Dr. Girish must have done more than 100 live workshops for girls in last 6 years. And this has been acknowledged by Foxy and Amogs time to time. I wish a very happy learning to all of you on behalf of Yavatmal, Pusat and Hingoli OBGY Society. Once again, from bottom of my heart, I welcome all the faculties, chairperson, delegates for and thankful for attending this webinar. Thank you. Over.
Thank you very much. Dr. Ajay Mane is there. Ajay is convener of the program, so may I request Ajay Mane to say a few words? Actually, there are so many programs going on parallelly with this program. Actually, one Amogs program is going on, so probably Ajay Mane is busy over there. So may I request now?
Hello, Girish, I'm here. I'm here, Girish.
Please.
Hello.
Ajay.
Yes, yes. Yes, thank you, Girish. At the outset, I convey my gratitude to Yavatmal Obgy Society and Pusat and Hingoli Obgy Society, though they have given me the honor of being convener of this great webinar. All the efforts were done by these three societies' president secretaries. So I welcome the Foxy office bearers, Dr. Shanta ma'am, Madhuri ma'am, Fesi, Bhaskar bhai, and my beloved brother Girish, and Amogs office bearers, Nandita ma'am, Nayak sir, Pardeshi sir, then Kiran Bandhu and Supriya. And the most efforting people, those who have taken all the efforts, Vrishali, then Gayatri Rathod ma'am, Nandini Vaidya ma'am, Yogita Zopat ma'am, Kiran ma'am, Chanchal ma'am, and Jadhav sir, and all the delegates who are attending today's great session of education. I appreciate the work done by Vrishali and Girish in the field of adolescent. They have shown the photograph. This is only 1% of their work. They have done a tremendous work in Maharashtra and all over India. And now Supriya is along with them. And maybe another few good people will be joining them. And I welcome you all. And thank you, Girish and Vrishal.
Thank you, Ajay. Thanks a lot, dear. Yeah. So now may I request Shanta Kumari Madam, President Foxy, to say a few words. I think Madam is not there. Actually, she conveyed me that she will be in flight at this time. So let me invite my dear friend and Vice President of Foxy, Dr. Asaf Mukherjee, to say a few words. Asaf Dara.
Yeah. Thank you, Girish. It's a pleasure to be here on your invite. Yavatmal is a society which we came to know for the last decade, as long as I am being there in Foxy, because you won so many prizes and you were so much very active. I have not had the privilege to be at the Yavatmal at any point of time. So I look forward sometime in this year or next to visit you and to really see your work as in person. Yavatmal must be very lucky to have a very active society and a very active couple in both of you, that you've done so great work in the schools, colleges around which you've shown. As I understand, Dr. Ajay has said, and I realize that you won so many prizes. This could only be 1% of what you have actually done, and it's remarkable the work you have done. And just to congratulate you both and to continue the good work that you are doing, and all the other societies too, Pusan and Hingoli. Again, I haven't had the fortune to be there, but it's wonderful to know that all of you are together in this academic prowess. So this is wonderful. This is your web series, I understand. And the biggest thing is that you've got the superstars when it comes to the important topics you've chosen. You've chosen Dr. Lakshmi Srikhand, you've chosen Dr. Rajal Thakkar, you've chosen the Sampath Kumari, you've chosen Dr. Durusha. They're the superstars of each of their fields in which you've chosen them. And so they will definitely attract crowd and eyeballs. And as you said, that even though there are many programs going on at the same time, I'm sure there'll be many people tuning into this particular one because of the super faculty that you have chosen and the very fact it's coming from the Yavatmal production house. Thank you very much. It's wonderful to connect, and all my best wishes for the film.
Thank you very much, sir. Thanks a lot. So now we take an opportunity to invite Dr. Fogsi. I think Fogsi sir is not there. Sir, are you there? Fogsi sir? Thoughts?
So Facey not seem to join basically, I think.
Yeah, I think Dr. Lalita Madam is also not there. Now let me take opportunity to invite Vice President of Amogs, Dr. Rajendra Singh Pardesi sir, to say a few words. Sir, good morning.
Good morning, sir.
Good morning. Good morning. Good morning.
Sir, आम्हाला आशीर्वाद हवेत तुमचे.
Oh, good morning, everybody. So, respected Dr. Shanta Kumari ma'am, Dr. Nandita Palsetkar, Dr. Duru Shah ma'am, Dr. Sampat Kumari, Dr. Asha Rao, and Dr. Basabda, and our two dynamic, energetic chairpersons of Adolescent Health Committee, Dr. Girish Mane and Dr. Supriya Arwari. They are doing really wonderful work, and they cannot do this work without Vrushali Mane is there. And of course, I congratulate all other societies also, Pusada and Hingoli, for organizing such a nice program. I am feeling proud and honored to be a part of this program by Fogsi and Amogs and on adolescent health issues. Dr. Girish Mane is very passionate about the adolescent health, always talking about adolescent health, and always his dream is to make the programs and every program and every wishes for adolescent only. I wish to congratulate the three societies, Pusad, Hingoli, and Yavatmal, for organizing this program. And congratulations to Dr. Ajay Mane also, convener of this program, and for his future endeavor in Fogsi as Vice President Fogsi in this coming elections in March. I wish every success to the webinar. Thank you so much. Thank you.
Thank you very much, sir. Thanks a lot. Thank you, Supriya. Let me invite Dr. Supriya Arwari, who is in dual, this position for this CME. She is West Zone Coordinator for Adolescent Health Committee of Fogsi as well. She is Chairperson of Adolescent Health Committee of Amogs. Supriya, over to you.
Thank you, Girish and Vrishali. At the outset, I would like to thank Shanta Kumari Madam, President Fogsi, and Nandita Madam, President Amogs, for allowing us to conduct such a beautiful program under the banner of Fogsi and Amogs. Vrishali and Girish, आपके लिए तारीफ लिखना कहाँ से शुरू करूं? पता नहीं चलता अदा से करूं या हया से करूं. आप दोनों इतने लाजवाब हो कि समझ में नहीं आता तारीफ जुबा से करूं या कलम से करूं. So both of you are such a wonderful couple. You all are so passionate about everything that you do. You belong to such a vibrant societies. It's really like Basabda and like Pardesi sir said, यवतमाळचं ते चांगलं नशीब आहे की तुम्ही दोघं तिकडे आहात त्या तिकडच्या स्त्रियांचा आणि खास करून ॲडोलेसंट हेल्थचा उद्धार करण्याकरता. So I'm really wishing you all the best. This is such a wonderful endeavor, and adolescent health is something that all of us need to concentrate on. And the lineup of speakers is absolutely stellar. I mean, there is no doubt this is going to be an extremely successful program, and I'm hoping a very extremely successful series. Thank you for roping me in. I am so honored to be here with you. You have done all the legwork, and I am only getting the accolades. So thanks for that too. हम बचपन के बारे में बात करें, एक सुंदर सफर जो बचपन से अल्लड़पन और अल्लड़पन से जवानी तक जाता है, और ये इतना महत्वपूर्ण पड़ाव है हम सबकी जिंदगी में. तो उस पड़ाव के लिए दो लफ्ज कह के मैं अपना विदा लेना चाहूंगी कि वो बचपन की बस्ती, मासूमियत भरी मस्ती, जब खुशियां थी सस्ती और सपनों की थी कश्ती, वो अपनों का प्यार, अनोखा निर्मल संसार, अपने खुशबू से अनजान कस्तूरी हिरण सी हस्ती, वो बचपन की बस्ती, मासूमियत की भरी कश्ती. So all the very best for this wonderful program, and as you know, always I am there for your help, support, and Girish has been more than a brother to me, a friend, philosopher, guide, mentor. I think the words will fall short, and then I will take up the whole time of this conference if I keep praising this couple. So all the best to you, as well as Pusad and Hingoli Society, to Gayatri, to your secretary Zopte Madam, And we have such a beautiful lineup of speakers. So I think we should start right away. Thank you so much for having me here.
Yeah, Girish, we can say that अब आई है सुप्रिया अरवारी, अब आई है शेरो शायरी की बारी.
क्या बात
Wow,
है?
wow, 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 क्या बात है. That's very
So I
nice.
think now inaugural part has been over. Now let's move to the academic station. Actually, we have two links. This is the faculty link, and there is one more link for the delegates. So all the faculties they have joined except Dr. Nisha. I'll be in contact with her. So for the first session, let me invite today's chairperson.
Voice is not that clear.
So, hello, Nisha.
Sir,
Girish, your voice is cracking. Girish, your voice is
Your voice
cracking.
is not clear.
the voice is very
Is
low.
it now? Is it okay now?
Yeah, better.
Better.
कोणाचं?
Yeah. So
माझे
now
वेबिनार
moving to
चालूच
the
रे.
academic
2
part
वेबिनार
of-
पॅरलल चालूच पण आता नको.
Now moving to the
Ajay Babu,
academic
you-
part of this program. So for the very first session, let me invite today's chairperson for the first session, Dr. Rajan Thakur and Dr. Lata Agarwal. Nisha, may I have CVs of Dr. Lata and Dr. Rajan, madam? Yeah, so I won't be going in detail of CVs of anybody because all the faculties, all the chairpersons, they are very well known to everyone. Dr. Rajan Thakur, madam, she is professor in Ahmedabad Medical College, and she's at present she is national coordinator of this Adolescent committee of Fogsi. Madam has a lot of contributions in the academic, in the Fogsi, as well as everywhere. She's doing many social activities. She has been awarded for many things. She has been felicitated for many things, and there are so many credentials in her, in her credit. So, can I have a CV of Dr. Lata, madam?
I think
Yeah,
Dr. Mane.
Lata Agarwal, a very good friend of mine. She is a consultant.
Thank you.
In multi-speciality hospital. She is past president of Obgy Society, and madam has been very good academic. Not only academician but initiating the Pusat Taluka. It's a small place, and she is rendering her services in the Pusat, and she must have done a lot of work in the in that area. So over to you, both of the chairperson.
Thank you, Dr. Mane, for your kind words.
Rajan madam and Lata madam, over to you.
Yes. Today's speaker, Dr. Lakshmi Srikhande, madam, needs no introduction, but just to complete the formality, the chairperson elect of ICOG.
Lakshmi ma'am's CV is not seen.
No,
Yeah,
I have shared my screen. Girish, you can't see it?
No, madam. No, madam.
No.
I will share again.
That's why I was
Yeah.
waiting.
Acha, because the corona people are trying. Please, you don't try. Let me share my screen.
Yeah, Nisha, madam.
Corona people, please don't try because
Now,
now my
corona
screen
means only one thing we think of.
can you all see my screen?
No, ma'am.
No, madam. It is not yet started. Only Lakshmi Srikhande has started screen sharing is seen on that.
नहीं ना यार अभी
No, no.
नहीं मैडम मैडम तुम्ही स्टॉप शेअरिंग करा आणि परत
बंद करो और मैडम को अलाउ करो स्क्रीन शेयर.
हाँ मेरे को स्क्रीन शेयर अलाउ करो फिर.
हाँ टेक्निकल टीम काइंडली स्टॉप शेअरिंग यू.
Ma'am,
You stop screen sharing and allow me screen sharing.
Ma'am, the screen sharing is allowed. You can just share because it is taking few seconds because the
देखो
Okay.
अभी हाँ.
Okay.
it has started. It will take just a second.
Okay, I will just wait. The moment you, हाँ अभी दिख रहा है मेरा screen share?
No, ma'am. No, ma'am.
It is.
हाँ. अभी
नहीं.
अरे यार ऐसा क्या हो रहा है?
Lakshmi, what you can do, you can mail your PPT to the technical team so that they can share, or you just mail it to me. I can share from my side or something.
नहीं, just a minute. मैं इससे login करती हूँ.
Although a green candle was there, but on one hourly chart, here you can see a evening star.
Meanwhile, I acknowledge the presence of second vice
देखो
president.
अभी दिख रहा है?
Yes, yes.
now it's in.
हाँ, मैं ये वाला click करती हूँ. Viewing.
Lakshmi madam, make it a full screen.
हाँ अभी क्या कर रही हूँ? Just a minute.
हो म्हणली तर पाठवून द्या. सांग म्हणजे
Uma madam, can you mute please? Uma Soni ma'am.
देखो अभी
Sure,
दिख रहा है?
sure.
Yes, ma'am.
Yes, thank you.
Yes,
Hello?
ma'am. Should I start?
Yes.
Yeah, Lata ma'am, please.
As I said, madam needs no introduction, but just for formality. Madam is chairperson-elect of ICOG. She is national corresponding editor of Journal of OBGY, national corresponding secretary, Association of Medical Women India. She is founder, patron, and president of ISO PARB Vidarbha chapter. She is chairperson IMS Education Committee. She is president Association of Medical Women Nagpur. She had got Nagpur Ratan Award at the hands of Union Minister Shri Nitinji Gadkari. She has received Bharat Excellence Award for Women's Health. She has received Mehrudara Hansotia Best Committee Award for her work as chairperson of HIV AIDS Committee of Fogsi in 2007 and 9. She has received appreciation letter from Maharashtra Governor for her
Girish,
work.
ते जे हे असतं ना
सगळ्यांना म्यूट करायला सांग गिरीश.
Save the Girl Child. She is Senior Vice President of Foxy 2012. She is President Menopause Society Nagpur from 2016 to 18. She is President Nagpur OBGY Society from 2005 to 6. She delivered 11 orations and 450 guest lectures. She had publications, many publications in her name, 30 national and 11 international. She sensitized 2 lakh boys and girls on adolescent health issues. This is a very short introduction of Madam. Please enlighten us.
Thank you so much. Girish, am I visible, audible? My slides are seen?
Yes.
Yes, ma'am.
Yeah, and thank you so much, Girish. I know how dedicated you are towards the cause of adolescent health education, and this is another feather in your cap. So I kudos to both Girish and Vrishali for taking up this great initiative and organizing today's conference on dedicated on adolescent health care. The topic given to me by Girish is adolescent AUB. So first of all, we should know what do we mean by abnormal uterine bleeding. Any bleeding which is abnormal in duration, volume and frequency is AUB, and adolescent AUB comprises of nearly 50% of our gynecological consultations in OPD. Whenever these adolescents come to us with abnormal uterine bleeding, we have to first determine the severity of the bleeding, and we have to try to find out possible etiology. I will tell you in differential diagnosis what can be the possible etiologies of adolescent AUB. But friends, even though she is an adolescent, don't forget to rule out pregnancy and pregnancy related issues, as most of the adolescents are sexually active. The second point I want to emphasize is that 20 to 33% of cases of adolescent AUB are because of bleeding disorders. So the history is detailed history taking is the first and foremost component of the evaluation, and it should be taken with and without parents. With parents, you should inquire about the details of the problem, and without parents, you should try to elicit whether she is sexually active or not, or what information she wants to confide in. Detailed menstrual history, of course, you have to take, but apart from that, you have to take history which can point out towards the bleeding disorders like prolonged bleeding after surgery or tooth extraction, epistaxis, gum bleeding, bruising. This all we have to inquire. Family history of coagulopathy or hormone sensitive cancer should be elicited. And remember, heavy menstrual bleeding is a subjective diagnosis. An adolescent might perceive 20 ml bleeding as heavy bleeding, but another adolescent might perceive 120 ml as even normal blood loss. So what we all can do, we all can have a pictorial blood loss assessment chart so that they fill out how many pads or tampons they are soaking, and you can evaluate as a treating doctor whether she is really having heavy menstrual bleeding. Now, general examination is must to look out for the signs of anemia. Gynecological examination is not needed unless you are thinking of some pregnancy related problem. Ultrasound is not mandatory as majority of the AUBs are because of anovulatory cycles or because of bleeding disorders. But whenever you feel like, you have to do ultrasound to rule out pelvic pathologies. And if she's sexually active, you can go ahead and do TVS. If not, you have to opt for trans-abdominal sonography. The minimum lab tests which should be done for adolescent AUB include the CBC, PS, ferritin level, prothrombin time, activated partial thromboplastin time, and fibrinogen. Adolescents who are at risk of bleeding disorders should undergo testing for von Willebrand factor, and this panel should include plasma von Willebrand factor antigen and functional test for VWF and factor VIII activity. It is important that when you are ordering this panel, it should be obtained when your patient is not taking hormones, because exogenous estrogens may elevate this factor into the normal range. Thus, if you are suspecting and you want to order this VWF panel, you have to do it at the time of presentation or after exogenous estrogen has been discontinued for 7 days. It is also important to obtain blood group type, since blood group O is associated with lower levels of VWF, and to consult with a hematologist if these levels are low. If you are considering bleeding disorders as a differential diagnosis for adolescent AUB, do involve hematologist into your team. This is the differential diagnosis. You all can see the causes can be hematological, genital system pathologies, pregnancy-related issues, endocrines, trauma, drug history. Please mute yourself. Drug history and the other causes which I would like to emphasize, since we are dealing with adolescents, is excessive exercise, eating disorders, stress. These can also contribute to abnormal uterine bleeding. Now, the first approach for management is definitely medical management for adolescent AUB. And the choice of treatment depends on the stability of the patient, overall acuity of the symptoms, suspected etiology on the basis of your history, evaluation, and blood test, and the underlying medical problems. So to simplify the management, it has been divided into mild, moderate, and severe AUB. Mild AUB, when she is bleeding for more than 7 days, or she is getting bleeding within 3 weeks of the cycle and hemoglobin is in the range of 10 to 12. Moderate is when she is having moderately prolonged or frequent menses and hemoglobin is more than 10. Severe bleeding when she is having heavy bleeding and the hemoglobin is less than 10. So for mild AUB, usually we don't consider hormone treatment. NSAIDs are enough, and patients can be called for follow-up at 3-month interval and should be instructed to keep a menstrual cycle diary. For moderate AUB, they can be very well managed on OPD basis. In addition to iron supplementation, hormone therapy is necessary to stabilize endometrial proliferation and shedding. And currently, there is no consensus on whether to treat them with COCs or progestin-only regimens. COCs, of course, are better choice as estrogen improves the hemostasis. We have monophasic pills containing 30 microgram of ethinyl estradiol. They are preferred to prevent the breakthrough bleeding. For moderate AUB, progestin only can be an alternative to COCs for adolescents who are not currently bleeding or have a contraindication for estrogen therapy. Progestin only options can be micronized oral progesterone, medroxyprogesterone, norethindrone acetate, depot medroxyprogesterone acetate, or a LNG device. The last two options are for those adolescents who also need a contraception. Micronized oral progesterone contains peanut oil, and you have to be very careful and cautious as far as allergy is concerned. For severe bleeding, that is where hemoglobin is between 8 to 10 Use of OCP is similar to that we use for moderate AUB. If there is no decrease in the severity of the bleeding following the first 2 doses of your OC pills, the dose should be increased to 3 to 4 pills per day for 2 days, and this dose can be continued as needed until the bleeding stops. All patients with severe anemia must be assessed for bleeding disorders. And don't forget to supplement with 60 to 120 milligram of elemental iron to these adolescents. If she is having hemoglobin of less than 7, or if the adolescent is hemodynamically unstable, she should be hospitalized and monitored. Arrangement should be made for blood transfusions, and she can be started on high dose OC pills, that is containing 50 microgram of ethinyl estradiol. This treatment with high dose estrogen is continued at 6-hour intervals until the bleeding decreases, and then you can decrease within 1 week as follows: 1 pill every 6 hours for 2 days, then every 8 hours for 2 days, then every 12 hours for 2 days, and finally 1 pill daily for a minimum of 6 months. Antiemetic therapy can be added for those adolescents who cannot tolerate high-dose estradiol-induced nausea and vomiting. Therapy is maintained with OC pills containing 30 to 35 microgram of ethinyl estradiol. Intravenous conjugated estrogen may be considered for those patients who cannot tolerate high-dose oral estrogen therapy. If oral treatment is not possible due to loss of consciousness, or if the severity of bleeding does not decrease within 6 to 12 hours despite high dose of oral estrogen. The use of conjugated estrogen treatment for more than 24 hours is not recommended due to potential side effects. Usually, the bleeding is controlled within 24 hours of OC treatment. High-dose progesterone is an alternative treatment choice in those patients with severe bleeding, especially where estrogen is contraindicated. There may be a need, along with the hormonal therapy, for hemostatic agents such as tranexamic acid, aminocaproic acid, and desmopressin if bleeding exceeds 24 hours despite high dose of COCs or there is a known platelet dysfunction. So this is the medical management for acute heavy menstrual bleeding. You can give conjugated equine estrogen, combined COCs, you can give medroxyprogesterone acetate, and you can also use tranexamic acid 1.3 gram orally or 10 milligram per kg IV. Maximum you can give is 600 milligram of tranexamic acid per dose, and the dose schedule is 3 times per day for 5 days, that is every 8 hours. Now I have told you in detail about the hormonal management. Let us come and see the non-hormonal management in a bit detail. Tranexamic acid prevents the destruction of fibrin and it decreases bleeding by 30 to 55%. However, it has no effect on the duration of bleeding or on the regulation of menstrual cycle. The recommended dose and duration are 3 to 4 doses of 1 to 1.5 gram per day orally or 10 milligram per kg intravenously per day for 5 days. NSAIDs, they decrease bleeding by preventing prostacyclin formation, and adolescents with HMB and a possible history of bleeding disorders should be instructed to avoid NSAIDs due to decreased platelet aggregation by inhibiting thromboxane A2 synthesis. What about desmopressin? It is a synthetic analog of arginine vasopressin. It increases the VWF and factor 8 levels as well as platelet addition, and its effect lasts for about 6 hours. Desmopressin combined with tranexamic acid is recommended as a good treatment option for adolescent AUB. When to consider surgical treatment? Remember, more than 90% of the severe bleeding that occurs in adolescents is controlled with medical treatment. However, surgery is required in those cases who suffer from life-threatening bleeding, where medical treatment is unsuccessful, and in situations where you need a histopathological evaluation. follow-up is very, very crucial. And this follow-up visit depends on the severity of AUB. During each follow-up visit, you have to ask for the compliance of the treatment. You have to check their menstrual diary. You have to educate the girl as well as the family members. Don't forget to provide education material in local language to them so that they can go through at home and she is well versed with her own problem. So to summarize, evaluation of adolescent girls present with heavy menstrual bleeding should include assessment of anemia. Routine USG is not mandatory. The first line approach to acute bleeding in adolescents is, of course, medical management. Hormonal treatment can be safely used in adolescents. Moreover, they have positive effect on school performance and on the social activities of this group by decreasing the number and severity of bleeding episodes without damaging the hormonal axis during the maturation process. So you can allay their anxiety that OC pills, you are advising them at this tender age. Adolescents who are hemodynamically unstable or actively bleeding should be hospitalized for management. As an OBGY, we have to provide important guidance to the premenarchal and postmenarchal girls and their families about the issues related to menses. And here is Girish Mane and his committee is doing a wonderful job by reaching out to adolescents and telling them about the adolescent health problems, about the menstrual problems, and also about the menstrual hygiene. We have to counsel these adolescents about the differential diagnosis of bleeding disorders, which can lead to heavy menstrual bleeding. And if we have diagnosed bleeding disorder as a cause of heavy menstrual bleeding, then you have to tell them that adolescents should avoid aspirins and NSAIDs, and they have to consult a hematologist. So friends, this was all about adolescent AUB in a nutshell. If you are having any questions, I am here to answer. Thank you so much for your patience. Thank you.
Thank you very much, Dr. Lakshmi. As usual, as always, it was a flawless presentation and so many great inputs. Going to give you one surprise. That is this. Just I'll have to change this. Wait.
Waiting for the surprise, huh, Rajal?
Yeah. But it is. Wait. Yeah. This is the Yuva Fogsi. Wait, I'll make it none. This is the Yuva Fogsi 2004, where you were the organizing secretary.
Yes.
And the talk that was given to me was on teenage metropathy. We are now moving from teenage metropathy to dysfunctional uterine bleeding to menorrhagia to AUB. So now we all need to coin this word and use this word AUB more in a positive way rather than DUB, because many of our colleagues are still using the word DUB. So we need to go for that. And history taking, as you have rightly said, is very, very important. We need to check about, because from history we can make out the coagulation disorders, because it is a very big chunk of the causes of the adolescent AUB and foreign body. I just shared one small experience. We have removed our dubbi from the vagina. We have removed cordie also, and we removed the plastic, some slipper material also from the vagina. So we need to check for the foreign body, and of course should not forget about the pregnancy related and the inadvertent taking of the hormones, because sometimes they are just taking emergency contraception if they are sexually active, and they use emergency contraceptive as a preventive method regularly. So we need to check for all of this. Congratulations for your nice presentation, and thanks Yavatmal Society, Amogs and Fogsi, and Girish Mane and Vishali for giving me this opportunity. Thank you very much, and all the best to all of you.
Thank you, Girish. Thank you, Rajat.
Thank you. Lata madam, you want to say something? Okay, so thank you very much, dear Lakshmi madam, Rajal madam, and Lata madam. Thank you very much for your wonderful session. Now let's move to the another one. And let me welcome the chairperson for next session, Dr. Kiran Kurtukoti, who is second vice president of Amogs, and Dr. Sheetal Agrawal, madam. Can I have CV of Dr. Kiran and Dr. Sheetal? Disha? So in 2 words, if I say something about Dr. Kiran, he is my big bro. Okay, now come to Dr. Sheetal, madam. She is consultant OBGY in Sanjeevan Multi-Speciality Hospital and Research Institute in Yavatmal. She is teacher for CPS DGO students in Sanjeevan Hospital. She is past president of YOGS, and she is a recipient of gold medal in PSM in MBBS Nagpur University, secretary of YOGS in 2006-07, and as I said she was president of YOGS in 2012-13. And in her tenure, my society, that is YOGS, has won Smriti Mailan Save Baby Girl Award and DK Tang Trophy and Sadhna Desai Population Stabilization Award. And probably Dr. Sheetal madam is one of the person who is the inspiration for all the people who are taking this seat of president of YOGS. And it is mandatory on our part to do something, something good to back these awards. So thank you very much, Sheetal madam, for gracing this occasion. Yeah. Nisha, next CV. Yes, now coming to Dr. Kiran Kurtukoti, there is no need of introduction of Dr. Kiran Kurtukoti. The first and the best introduction of Kiran is he's my big bro, and he has been teacher to me for not only the social but the academic things in the Fogsi as well as in the Amogs. Thank you very much, Kiran sir. He has been, time to time, he was guiding me for many things, and right now he is second vice president of Amogs, and he has, honored many posts in Amogs, in Fogsi. There are so many credentials in the credit of Dr. Kiran Kurtukoti. Actually, this will take a lot of time if I go on speaking about Kiran Kurtukoti. So over to you, both the chairperson, for the next proceedings.
Well, at the outset, thank you, Dr. Girish, Dr. Vishali, for that kind introduction and involving us in this particular webinar. And my regards to the presidents of Yavatmal, to Pusad and Hingoli Society. It's a privilege for me. Also, I acknowledge the presence of Rajal, my old friend in Fogsi, and our candidate, Dr. Ajay Mane. Dr. Ajay Mane, best wishes to you. And it's really a pleasure for us to introduce Dr. Duru Shah, our next speaker. Can we have a CV? Dr. Duru Shah? Yes. Apart from being the president of Fogsi, she is the director of the Kaidiva, that is the Center for Women's Health and Fertility. She is the founder, trustee, and the president of the PCOS Society of India. Now, you can imagine that what goes on in the mind of such a great person, that she can form a society of a particular disorder. So you can imagine the expanse of that disorder. So thank you, Dr. Duru Shah, for forming this particular society. And really, we do look forward to all the newsletters that we are receiving from the PCS Society. So hats off to you for this particular venture of yours. So thank you so much. She's of course the first and only Indian to receive the FIGO Distinguished Merit Award. Again, a proud moment for all of us Foxians. She has received the Black Swan Award for Women Empowerment. She has received the ICOG Vidya Bhushan Award for her distinguished role in the medical education. She is featured in the India Today magazine for accomplishment and commitment to medicine, and one of the top docs in Mumbai 2020 and 2022. And Dr. Duru Shah, we always look forward on 1st of January for your New Year greeting cards. So thank you. Please posting them. Please keep us posted on that, so that we remain connected to you. So thank you so much for everything, and over to you for your oration now.
Thank you so much for this invitation and this kind introduction, Dr. Kiran. We have worked together for many years, and it's been a pleasure to see you again. We have worked with quite a few of you, all of you actually, especially Rajal, who has been with us for a very long time and is doing fantastic work. Both Dr. Girish Mane and Rajal have taken up adolescent health beautifully. So I think I did not say no to Girish when he called me a few days ago. And I said, honestly, it's too short a notice to prepare a fresh talk, but I'll speak something on what I have spoken before. So recently, with the impact of COVID, what we had is, and how it has affected PCOS adolescents is what I'm going to talk about. So let me come to the situation is where, just now my laptop is not really working great, but I have got my presentation on my screen and I'm not able to, you will not be able to see me whilst I'm talking. So please pardon me for that. I'm speaking from my iPad and this is something which, is it getting shared? That's what I would like to know.
Not yet, madam. Not
Are
yet.
you able to see the share?
No, madam, not yet.
No? This is my biggest challenge with the iPad and can someone help me with how to share it on this? Because on the laptop, I can do it well, but there's something with the updates on my laptop. So let me go back to, so this is my PowerPoint presentation, but I'm not able to share it. So we come to the share content, Microsoft.
Nisha, can you guide me, madam?
SharePoint.
Once. Ma'am, is your presentation open in iPad? Or
Yeah, it's opened in iPad actually.
You got connected to iPad?
Yes, I'm connected and it's showing here share content on the screen on Zoom.
Mm-hmm.
And I'm clicking it, but what it shows is that I can share my iCloud Drive, Dropbox, Microsoft OneDrive, SharePoint. Let me try. It's not showing how I can share my screen. That is my problem. So you have anyone there who can help me with this?
Ma'am, is the presentation on your screen? I mean, you have
Yes.
downloaded it?
Yes.
Is it in the downloads or in the iCloud?
Yes.
Once try it again, ma'am.
The share content, iCloud Drive. There are so many other things which are there. I'm not able to see the screen. Gosh. I've used it just a few days ago and I'm forgetting how to do it in short. You don't have a technical person here, right?
Presently. Ma'am, what do you do is you mail it to me, ma'am. I'm just sharing you the email ID.
Okay, fine. Take it.
Then I'll share from my side.
Madam, Nisha is a technical person. She's helping you.
Okay. No, but then will you be able to give me the control or no?
I will be sharing it from my side. Whenever you say me next.
No, but you will be able to give me the control instead?
That will not be possible, ma'am.
There are ways on doing it. I've done it before, but I'm mailing you the slides.
Yes.
Give me the email ID where to send it.
I have just shared it in the chat box.
Okay, I'm sorry about this delay.
It is Nishat, NISHAT at.
Yes.
Shared it on email?
Okay.
Yeah.
It's not coming.
I have shared on the chat box, ma'am.
No. Put it on my email. No? It will come through my email. It's durusha@gmail.com.
Okay, 1 second. I'm just sending you a text mail.
Nisha, send her a mail at durusha@gmail.com. So she will attach the file and send it back.
I'll share. I have shared on that.
Thank you.
Okay.
Have you received my mail, ma'am?
Yeah, I just got it. Give me a minute.
Okay, you can just share me the details.
I've sent it to you.
Yes. Yes, I've received it.
Madam,
I
meanwhile,
don't know why. The laptop acted very funny today. It kept telling me that I need to update some app, which caused me trouble. So I said I'll do it from the iPad, and unfortunately,
no issue.
it's not
Madam,
showing.
actually, we are having two links. The separate link for the delegates, and there are many delegates on the another link, and we are 27 to 30 faculties. So we would love to hear about your app, and it's too shy to.
So where did
I'll take a minute. There is no attachment in that, ma'am.
Oh Lord. Just check, please. Otherwise, I'll have to talk without the presentation. I can do that. You wanted me to do that if it doesn't work now?
1 second, just I'm checking if the presentation attachment is there. No, there's no attachment, ma'am.
It's come to me as a attachment from my secretary, and I'm sending the same thing to you.
No, ma'am, there's no attachment in this.
So what should I do? Should I just talk?
Madam, I guess you need to download that attachment and then forward. Unless you download
No,
it.
I have downloaded it.
Okay,
I've downloaded it. Now I'm again going to try once more to send it.
Ma'am, there will be an option to include attachment or do not include attachment. You have to click on the include attachment and then forward.
Sure. It's terrible. See, I've opened my presentation, right? And I'm sending it to you again on mail to Nisha. Just tell me your email address again.
Nisha T.
Yeah, I've got it.
@Corona Remedies.
I've sent it once more. I hope it's the last time. Has it come?
No, ma'am, not yet.
It's showing that it's coming at least.
Just refreshing. Yes, I got it, ma'am.
Okay, good. I'm so sorry about this delay, but let me speak a few words on what really is happening with the adolescents, in India. We've been having a large number of PCO patients who are adolescents coming to us from various age groups. starting from the age of 13, where puberty starts. And it just continues, and we have them very, very obese. Some of them are so obese, they're over 100 kilos. And this is the kind of scenario which we are having. And that is why we talked about, in my presentation, I'm talking about why we are discussing this, why COVID affects women more as compared to men, and therefore how adolescent PCOS is something we need to seriously think about. So I'm glad I've got the presentation on, and if I could still get the control, I'll be very happy because I'll be able to go faster if you can work on that. But otherwise, let's get on to the talk. Next slide.
Start the presentation, ma'am. I'll try doing that.
Yeah. Go ahead, please. So we are talking about COVID-19, which came in on February 11, 2020, and WHO announced it, as the novel disease which is caused by this virus. And this is something which we understand that because I'm trying to get the self-control, it's not happening. Okay. No, it's not happening. It's not working. Go ahead with the next slide, please. And as in 21 Feb, this was about 1 year after the COVID, there were more than 100 million people affected from 210 countries, which caused a lot of physical and mental health. It affected everyone's lives, and it's still affecting us today. But I think science moved in very quickly and helped. Even now we have vaccines to prevent it. So in 1 year later, if we look at 2022, we are 2 years from the time we had COVID as a lockdown. And today we are so advanced that we've already started administering booster vaccines, and everything seems to have opened up. And I think we are fortunate in our country that we have got this opportunity to get our vaccines very easily. Next slide, please. So research has demonstrated that COVID-19 affects the pulmonary system, the vascular system, the gastrointestinal system, cardiovascular system, and the renal system and central nervous system. So you have a, next slide please. So you have a situation wherein the COVID-19 is affecting everything. And we know today through the research over the last 1 year that it is the ACE2 receptors which are present on a cell, which facilitate the entry of the coronavirus into the cells. And when it gets into the cells, it causes immense damage to the endothelial vascular system, it affects the immune response, it creates an inflammatory state, and it contributes to the involvement of multiple organs. And that's why you end up with multiple organ failure. Next slide, please. Both men and women are equally affected. They both do get affected, but we have seen that the disease is more severe in men versus women. And this gender disparity has been observed in many studies. And this is why researchers started looking at the influence of male hormones on the immune response to COVID-19 infection. Next, please. So when they started looking at more and more studies, they found that men, who had premature alopecia, early, androgenic alopecia at the age of 30, 35, they were being affected more often as compared to the men who did not become bald early. And similarly, they found that in women who had androgenic alopecia were also getting affected much more than women without androgenism in their body. And those patients in men who had prostate cancer and those who were given drugs to reduce their androgen levels, they found they were less likely to be infected. See, all this pointed to that having high androgens increases the problem and the severity of COVID. And therefore, we say that PCOS girls or PCOS women who are hyperandrogenic, we know that, could also be having a problem of increased severity of COVID-19, which may occur in those women who have PCOS as compared to non-PCOS women, and in women compared to basically in those cases. So next slide, please. So I'm trying to build upon the fact that is the androgens in PCOS women, which probably are the reason for them having a more severe form of COVID as compared to women who are PCOS, but not hyperandrogenic. Now here we have a situation, if you look at the receptors the ACE2 receptors are widely distributed all over the body, and they are in high expression in patients who have got, if they are present in high expression, then the androgen combines through these receptors and it causes, the COVID virus connects to these receptors and causes severe disease in a woman who has got high androgens, or in a man who has high androgens. Now here we find that the virus affects the cell surface, enters the lung cells, and causes higher morbidity in men. Next slide, please. So in PCOS, as I've mentioned to you, is really a situation where we don't know what really causes it, but we know that there are polycystic ovarian ovaries, polycystic ovarian morphology of the ovaries, and whether it is the hyperandrogenism causing those PCO ovaries or whether it is the ovaries causing hyperandrogenism, there used to be a conflict. But today we all know that it is the ovaries are looking polycystic. It is because of the hyperandrogenemia in a PCOS woman. And today PCOS is considered as a pro-inflammatory disorder. So similar to what happens as an inflammatory disorder in COVID. Next slide, please. So when we see women who are at a higher risk during COVID-19, they usually are at a higher risk because of obesity, hyperandrogenism, ethnic background, low vitamin D levels, lean PCOS, and fragmented treatment. So in short, we have got a situation wherein women who have got PCOS may have any of these conditions which may cause a problem. Next slide. So when you look at obesity, we know that there is a lot of morbidities. We know that there's diabetes, hypertension, cardiovascular disease, renal diseases, and all these we know that obesity affects the severity of every infection. And 80% of our PCOS women are obese, and a large percentage of them are also insulin resistant. So there's a lot of metabolic disease present in PCOS girls, and they are the ones who can get affected more heavily with COVID, with more severe form of COVID disease. Next slide, please. Next slide. So why does that happen with obesity? When we have increased adipose tissue, there is a higher expression of ACE2 receptors. There's an increased presence of coronavirus, which attaches to these receptors, and therefore there's a greater exposure and increased risk of severe disease. We also know that obesity itself is a chronic inflammatory state. And therefore, in women who have got PCOS, who also have a chronic inflammatory state, this entire thing gets exaggerated. And then we also have a situation that with COVID-19, there's increased viscosity of the blood, there's increased risk of thrombosis, which also happens in PCOS women who are obese. So all this increases the risk of morbidity and mortality in PCOS women and girls. Next slide, please. So here is a situation where we are talking about PCOS affecting women who have got PCOS women having hyperandrogenemia. And in India, we have 1 in 6 women with PCOS, and therefore they are at an increased risk of susceptibility to severe infection of COVID. Next slide, please. So then we say that there are different phenotypes of patients. They all don't have everything, but we know that phenotype D has chronic anovulation, means irregular periods, and polycystic ovaries, but they don't have any androgen excess. So the question is, do these women or these girls who have got PCOS with no androgens, will they have a less severe form of COVID-19? We still don't have evidence on that, but that's a hypothesis which people are working on. Next slide, please. So where Indian women are concerned, why we are at a higher risk again? That's another issue we have to look at. Being Indian and being PCOS, higher risk. Why? Because studies which have been done in UK and they compared, the Asian population there compared to the other blacks and the other ethnic population, they found that this whole group as compared to the UK group, that's a Caucasian group, had an increased risk of death from COVID-19 in England. 63% of 106 healthcare workers who died were from this particular background. So this is evidence which is there available in the literature. Next slide. So we, as being Indians, being PCOS, we are at a higher risk. If we are obese, we have a higher risk. If we are hyperandrogenic, we are at a higher risk. The other reason why you may be at a higher risk in India is because we are living in joint families. There's less social distancing. Many of us are living together, and there may be people going out. There are different genetic variations of the androgen receptor found in South Asian population, that is in Indians. They have found that we have a different genetic variation of the androgen receptor, and therefore we are more, susceptible to severity of this disease, and Indians compared to the UK citizens would have a lower socioeconomic status. So this is in the study which has been reported in 2021, which is 2020 Lancet. Next slide, please. The other reason is low vitamin D levels, but I suppose in India, most of us have low vitamin D levels, but it has been shown that vitamin D modulates the immune responses. It regulates the IL-6 activity and it suppresses the pro-inflammatory responses of various viruses. And therefore, giving vitamin D to such patients may probably help, and we need to, sort of give them that therapy whilst they are having COVID. Next slide. So when we have lean patients, what happens? We know that in lean patients, we underdiagnose them. Because they are lean, we feel, oh, she can't have PCOS, but that is wrong information. We know that 20% of our patients are lean, and therefore, even if she's lean, she will be at a higher risk. On the contrary, we find those are the patients who have a higher risk of hyperandrogenemia. Next slide. The risk factors for COVID-19 in women with PCOS is mainly because women go to different physicians at different timings. For irregular periods and infertility, they go to the gynecologist. For women who are having cosmetic issues, they go to the dermatologist. If they've got obesity, they go to the endocrinologist. And therefore, there's a lot of fragmented treatment which is happening. And that was the reason we started the PCOS Society of India, where we brought in all the physicians from different communities, from different disciplines under one umbrella, so that we could work together and remove the knowledge gaps whilst we are treating PCOS, in patients in India. And therefore, this entire cocktail of a predisposition of having a higher risk of COVID-19 severity as being a PCOS patient, the risk of having ethnic population, ethnicity, Indian ethnicity, and the risk of having a pro-inflammatory disorder as PCOS causes a lethal cocktail, which can give rise to severe PCOS. Next slide, please. So coming to the, we know that PCOS, as I mentioned today, is more, I'll skip to these slides. Sorry. Is anyone telling me something? Is COVID-19 more severe in PCOS versus non-PCOS women? Can somebody switch off their mic, please? Can they mute yourselves? I cannot speak otherwise.
Technical team, please mute everyone except Guru Madam.
When we are talking about PCOS versus non-PCOS women, there has been ample data. Next slide. Next slide, please. That there is a total 60 protein biomarkers have been assessed for vessel damage, etc. I think I'll skip these slides. We are running out of time. So let me skip these slides. Go to the next one. Next. There have been biomarkers found in PCOS women compared to non-PCOS women, shows that there's a higher risk of PCOS versus non-PCOS. So this is based on the studies which have been done, and they've found that a larger number of PCOS women have a higher amount of these protein biomarkers for COVID-19. Next slide, please. Now, when we talk about the risks which occur with adolescent and young adolescents, which they faced during COVID, it affected their sexual reproductive health, their mental health, and their physical health. Next slide. Next slide. Pandemic led to lockdown. A pandemic led to the lockdown of non-essential services and travel restrictions, There were, these services were abortion services, contraception services, nothing was available. So there were many young people who were pregnant and could not access safe abortions, and they got into serious trouble. There was a lot of economic hardships and gender-based violence. And this has been seen in many desperate adolescent, young adults and adolescents. Next slide. In Uttar Pradesh, if you count it as the most populous state of India, there are 5.8 million couples having no access to contraceptives between March to September 2020. And when they did not have access to contraceptives, it has been estimated that there may have been already 421,000 unwanted pregnancies which occurred in those 6 months, 120,000 live births, 256,000 abortions, and 309 maternal deaths. So this is what could be assessed, but then at the same time, there was so much more which happened, which could not be assessed because those adolescents either could not reach reach services, or it went unattended or unquantifiable. Next slide. So there was a lot of gender-based violence which occurred within the homes. There were so many girls sitting in homes where there were so many young men around and probably living in the same community. There was a lot of, no social engagement. People were trapped in abusive situations. And due to the economy dropping, about 4 million girls have given up their education, and there's increased risk of child labor and early and forced marriages of these young girls. Next slide. So this is what has happened during COVID. This particular study we carried out on our own between 16 to 25 years of adolescents, and 236 of them. And before the lockdown, we found that 34% was sexually active. And during the lockdown, we found that 58% were sexually active. And this is right, I'm sorry, 58% were sexually active before the lockdown and 34% during the lockdown. So the sexual activity did decrease. 3.4% were sexually abused and 5% had difficulty accessing safe abortion care. This is adapted from a survey and assessment of young people and COVID-19. Next slide. The mental health was also affected, and there was a lot of schools, colleges which remained closed, and because of which they were surrounded by their parents all the time. There was a lot of nagging going on. There was social distance from their friends. They were confined to their homes. There was no physical activity. Obesity increased. There was excessive use of unsupervised internet. There was family violence and disruption of daily routines. Next slide. Next slide. The online survey for mental health, which was carried out and a study reported, showed that 34.7% showed no interest in doing things. 32% were depressed on more than half the days. 52% were unsure about seeking medical help because they were not getting access to medical help, and not a good response because even doctors were quite often not available. 24% were not aware of the mental health helpline which had been set up. So the majority indicated that they wanted to seek help from parents or from siblings because they could not reach out to their friends. Next slide. So there was a lot of issues which happened. Next slide, please. There was a lot of issues which happened, and the online survey which we carried out on mental health between 15 to 35 years of age, unmarried were 368, married were 112. Mental health issues were 57.9% after the lockdown as compared to prior lockdown when it was 36.8%. Next slide. 75% of the girls gained weight during the lockdown, and the reason was because they were not able to follow a heavy diet and exercise. 65% of them had cosmetic issues prior to the lockdown, and they could not go for their laser therapy, and they were extremely concerned because of the excessive facial hair which continued on their face. And they were at the point of, actually, we read their letters, and they were at the point of suicide because they were so disturbed by the excessive hair on their face. Next slide, please. So in short, when we are dealing with PCOS girls and women who are on this therapy, there are a lot of indications of how we need to change therapy in these people, in these women who have got COVID. And we know that women with PCOS are on metformin, anti-diabetic drugs, antihypertensive therapies, glucocorticoid therapy, and therapy for obstructive sleep apnea. So there are recommendations based on this which are available online, and we need to read them so that we know, next slide, so that we know which patients, how we need to change their therapies. Next slide. We know that in women with PCOS, as we mentioned earlier, and COVID-19, there's a higher risk of thrombosis, especially if they are on oral contraceptive pills. We need to tell them to switch it off. And obesity, it's a dual problem. I mean, the patients girls are having irregular periods, not able to reach doctor, having heavy bleeding. They continue their OC pills. The obesity increases. They are not able to exercise. All this leads to thrombotic events and causes sometimes cerebral thrombosis. So it's a big problem, and there are big solid consequences and long-term consequences in these young girls. Next slide. And therefore, we need to pay attention to this and think of whether we need to develop new policy recommendation to address their issues in future. Next slide. So in short, there are a whole lot of suggestions which we are talking about, utilization of digital technology. Now everyone's got used to it, and telemedicine is coming to the front. Social media is being used for mass propaganda. Unfortunately, if you look at young girls, only 1 in 5 young girls have access to mobiles and internet in the rural areas. And therefore, we need to press upon our government to help us to have more technology available in the rural areas so that young girls and women can access the net and get knowledge on the subject. Next slide. Next. So the recommendations are, of course, to increase awareness also on sexual reproductive health, which is through education, through online education, which we have also done through my foundation called the Too Shy to Ask app. We also need to reinforce positive social outlook, educate young people, promote digital resources, and assure the young people that their care will be confidential. So when they are on their phones or on the internet and talking to doctors or getting knowledge, they are sure that they have got privacy, which does not happen in most of the general hospitals or crowded hospitals where, women have to give their history in front of 20 other women. Becomes very difficult. Next slide. Next slide. So we have to improve the healthcare services too. We need to have possibilities of confidential care, coverage of contraception and counseling. We have to provide HPV vaccinations. We need to reduce the barriers to this healthcare by making safe abortion easily accessible everywhere in the country rather than only in urban cities. Next slide, please. We need to include the LGBTQ individuals and people of all religions and caste. We need to create peer educators, and we need to create COVID warriors in villages for community health education. Now, this all is happening, not that it's not happening, but we need to include a lot of other stuff which is not yet happening. Next slide. We need to increase the financial assistance to healthcare. I think in this current budget, there was a little extra money given into the healthcare budget. But yes, we still need much more to reach out to all the adolescents all over the country, especially the PCOS adolescents, because they're at a high risk of having major complications. Next slide. We need to create public-private partnerships with NGOs, create youth-friendly services as we had created Kishori in Dharavi earlier. And through V Foundation, I had created another youth-friendly service in Dharavi through the Women's Empowerment Foundation. Unfortunately, with COVID, with no staff being available, we had to shut down that clinic at that point in time. Hopefully, we should be able to restart it soon. But this needs to go all over the country. 1 or 2 clinics don't really mean much, but we need to reach out all over. Next slide. So the Too Shy to Ask app, I think all of you have known about it. Next slide. It's available on Play Store and App Store, totally free of cost, available in 5 languages. And it's been done through the Women's Empowerment Foundation. Next slide. We also have a website called Conquer PCOS, which is being run for PCOS patients to give them all the information which they need on the subject. And that is something also is largely attended with a lot of PCOS women. Next slide. So the key messages are again that young individuals who are adolescents with PCOS especially, they are at a higher risk for physical health versus non-PCOS women. They all need information on increased reproductive and sexual, mental and physical health issues, and more so the women who are affected with PCOS. And we also need to reach out to the young people to reduce morbidity and future health in the years to come. The youth are our future, and they are the ones who are going to take our country ahead, which I've said way back in 2006. And today, the young people, if they are involved in the economy of the country, they are the ones with the brains. They are the ones with the active brains they have, and they can multitask and they do a lot. They can absorb much more than what we people can at this age. And hence, getting them healthy will make our country healthy. And using telemedicine more often will reach out to them and prevent morbidities in future to treat them. Next slide. We introduced telemedicine through ISRO, again in 2006, even before the digital medium with Zoom was available to us. We reached out for 3 years, for a lot of study programs with young people in rural areas. Next slide. That was through the satellite school. And then the use of social media is being used very well today. We must involve the young in making policy recommendations. They are our most important stakeholders in the country. We must involve them in our policy recommendations for the young people. Next slide. So as we look back on 2020, we may see many things that went wrong, but let's see this time as an opportunity when digital education takes center stage. So I thank you very much for your kind attention, and I'm really, really sorry about this lapse which has occurred, and I have to figure it out by tomorrow, and I'm sure the next lecture will be fine. Thank you very much.
Excellent presentation, madam. Thank you so much. Thank you so much. There's so much to learn from all of this. You know, the apps that you have told, and definitely I would be going ahead and logging on to the Conquer PCOS website that you have shown. We never knew this thing had so much outreach. So thank you so much for that excellent oration. And any other comments from anybody? Girish, Vishali, my co-chair.
Chital, madam.
Thank you. So sorry. Sorry, Girish. I'm again apologizing to everyone. I'm so sorry.
Oh, ma'am. No, ma'am. It's okay.
I just have to mention that I have fondest memories of Durusha madam. When I first interacted with her way back in 2006, when she helped us arrange Youth Express at Yavatmal.
Yes, we did it all over the country. It was a great.
Yeah.
I remember people telling me, why are you talking about the youth? And, you know, honestly, I think I was just this is what I foresighted probably. And I think 15 years now, we are talking later, we are talking a lot about the youth. And it was a good beginning, and we put in a lot of effort. And I think we've reached where we wanted to reach, and we need to go further. Thank you so much.
Thank you so much, madam.
It was always a pleasure to listen to Duru madam, always.
Thank you.
Thank you, madam. Thank you very much.
Madam,
thank you.
So short noticed invitation, and truly on behalf of all 3 societies, I'm grateful, and thank you again.
Thank you, madam. Thank you very much.
Thank you. Thank you.
Yes, ma'am. Yes, friends. Now it's time to move to the another session, and let me invite the chairperson for next session, Dr. Supriya Jaiswal and Dr. Nandini Vidya. Can I have a series of Dr. Supriya and Nandini? Nisha? Yeah, Dr. Supriya Jaiswal, very good friend of mine, and at present she is East Zone Coordinator of Adolescent Health Committee of Fogsi. She has been member of she's a member of Adolescent Health Committee Fogsi since last 3 years. Then she's executive member of ISAR Bihar chapter. Then IAG Patna chapter. She is a trainer for colposcopy of Fogsi. Then she has been awarded MP John and Dr. Murthy Award for best short paper in obstetrics. Then she is a recipient of numerous awards and certificate. She has contributed in Fogsi Focus. There are so many activities we have done together. Even she is instrumental in many social activities, and I was part of one of the very great activities she performed in September 2021. Last year when I was there, it was a Adolescent Health Week, during which Dr. Supriya has contributed a lot. So may I have CV of next chairperson Nandini?
Thank you, sir.
Yeah, Dr. Nandini Vaidya Bhagat, she is president of Hingoli OBGY Society for this current year. She is consultant OBGYN and practicing in Hingoli since last many years. She is director of Bhagat Hospital Hingoli. Actually, she has done her DGO in the SVN GMC where I was lecturer, and she was a great. I'm not only the student, but she was one of the best surgeon in during that tenure. She was university topper in first MBBS Nagpur University. She was past vice secretary of IMA Hingoli, past treasurer of Fogsi Hingoli, and many other posts she has in her credit. Now over to you, both the chairperson, Dr. Nandini and Dr. Supriya.
Yes. Thank you, sir. Thank you very much. Good afternoon, and I bring warm greetings from Patna OBGY Society in capacity of Secretary of the Society. At the outset, I would really like to thank the Yavatmal OBGY Society, Pusat Society, and Hingoli societies. So they have focused on the Adolescent Health Committee of Fogsi and dedicated web series Adolescent Health. I also thank the Fogsi office bearers, Dr. Shanta Kumari Madam, Dr. Madhuri Patel, Dr. Fessi Sir, Basab Sir, Dr. Girish Mane and Dr. Vaishali Mane, the really wonder couple. Very wonderfully you have conducted. I liked the first part of it where you showed all the activities. I'm awe of it always. I appreciate, sir. And it was wonderful. And thank you for the opportunity. I really thank each and everyone, Girish Mane, sir, Dr. Ajay Mane, sir, for being the convener of this program, and the wonderful speakers, Dr. Lakshmi Srikhande, Dr. Duru Shah, who is a stalwart in this field, Dr. Sampat Kumari Madam, and Dr. Asha Rao. So, and thank you all the OB secretary and presidents of all the societies. At the outset, I would just like to, can I have the CV of the speaker, Madam Dr. Sampat Kumari Madam? Thank you very much, sir. We had really good time with the programs, Girish sir, and till date, people remember the big program we had at all Bihar societies. It was wonderful. Thank you. So, Professor Dr. S. Sampat Kumari Madam, she really needs not much introduction, no introduction, in fact.
Yes, Supriya, no need. Past
Yeah,
Health
but
Committee
let me tell,
that's all.
Oh, Madam, you are Fogsi Vice President-elect to 2022, Founder Secretary of TNFOG, National Correspondent Editor, then Chairperson Fogsi Adolescent Health Committee 1618, where she had tremendously worked hard, and she had come to Patna, and we had really good scientific sessions, adhered physical programs when we had. Madam has many accolades to her credit. Madam is IMA Doctors Day Award from so many awards she has got. Fogsi Dr. Duru Shah Award, Fogsi Dr. N.A. Pandit and Mr. Shailaja Pandit Women's Empowerment Award. She has written chapters in Fogsi textbooks, Fogsi Focus and newsletter. Madam has got so many things that I cannot just explain so much. So, Madam, thank you very much. It's honor for me to chair your session. Thank you. Thank you, Madam.
Thank you, Dr. Supriya. First of all, I should thank Dr. Girish. If you think of Girish, only adolescent.
Yes.
When I was the Adolescent Committee Chairperson, the first booklet I received is from Dr. Girish during my first year. And during my 3 years, he did lot of program. And last year, I cannot forget, I think. I didn't go to Yavatmal, but other places, Aurangabad, other place, everything we had. Fantastic. Anyway, Girish, you have done a wonderful work.
Thank you, ma'am.
No one can match, I think. Supriya, can you see my screen?
Yes.
Yes, madam. Yes.
Good
Welcome,
morning,
Sampath
all.
Kumari, ma'am.
Again, I thank Dr. Girish and Yavatmal Society, Pusat and Bengali and Adolescent Health Committee of Amogs for giving me a wonderful chance with the topic which I am always for. Okay. Say all of us know that the adolescence, it is a transition from childhood to adulthood. We cannot consider that they know everything and they don't know anything. So it is a transition. As per WHO, the adolescence from 10 to 19 years. As early adolescents, where the secondary sexual characters develop, middle adolescents, where they want the separate identity, and late adolescents, they have the well-formed opinions. This is why we should always only thing which the adolescents don't like is advice. So whatever you want to give them as information. Don't give them as advice. Why we want to focus on adolescents? Because with the populations, 253 million, 20.9% is adolescent. And as per statistics, in 2030, it may rise up to 40%. And India is the only country with highest population of adolescents. Now that today's adolescents spending time with the parents, this is the way. Communication is through the cell phone. And next, most of the time they are with the friends. And the entertainment for them is Instagram, webinar, whatever it is. How it has to be solved. So what is the adolescents today? For this, they don't have understanding about what they need. As I told, it is a transition from childhood to adulthood. They think that this is needed for them, but we should tell them whether it is needed or not. And sometimes they feel shy, and sometimes they are very embarrassed and hesitant to talk to adults, that too mainly with the parents about the personal problems. Then sometimes they don't even seek the care for the problems. They don't know where to get the guidance, whether from the friends or from the parents or from the teachers. And they are more comfortable discussing with the friends only, but they don't know that with the scientific things, the friends are at the same level as them. So they are very happy with discussing the problems with friends. To avoid everything and to give the answer to everything, we need an adolescent health clinic. So that should be adolescent friendly health services. So that is the need of AFHC. See, as all of us know, this RKSK, that is the community-based health problem and preventive care for adolescents, started the adolescent clinic in 2006, where it discussed only about the sexual and reproductive health issues. Then it started discussing with the sexual and reproductive health issues, nutrition, substance abuse, injuries, and violence. So to have a discussion of everything, adolescent health clinic is needed. See how this adolescent health clinic can help the adolescents, that we can see. See, this is a girl with a low hemoglobin and she is not able to concentrate, but she don't know where to get the advice and whom to contact, because her family is a joint family and she is not able to get the good nutrition also. And other hand, we have such a type of adolescents who are having all sorts of habits, even the smoking and alcoholism. So what it should be? So the adolescent health clinic should be equitable. So it should be a services provided to all adolescents who need them. So it should cover all the adolescent people. Next, this is the school going. Most of the time, we know there are some students, they don't even have the bus facility and they don't have many facility for the transport. They go by walking itself. So what should be the adolescent health clinic? It should be accessible, readily accessible. So it should be nearby. Where it should be by? It should be in a district headquarters or it should be in a private. Wherever it is in the nearby, even nearby clinics can have the adolescent health clinic. They should have, but it should have a privacy. Accessibility is very, very important. And it should not be near the labor rooms. And it should not be near the NCD, that is the counseling centers for NCDs. And NACO counseling centers, STI counseling centers, it should not be near. Then what? This is the thing. A girl, Nowadays, we are having about the respectful abortion care also. In that, what they tell, whether married or unmarried, whatever it is, abortion care is given, that is respectful abortion care. If the adolescent girls, knowingly or unknowingly, she is becoming pregnant, means she is very afraid where to go, where to tell to the parents or to the teachers, where to get the service. I heard one of the girl telling that when she went to the doctor scolded her like whatever which the girl didn't like, the way the doctor talked. So this is the place where acceptable health providers, what the adolescents need, whether this girl wanted for abortions or we have to follow the MTP Act, Fox Act, that is different. But what the girl is wanted, that should be done. Whether if she wants to continue also, whether she wants the abortion. So the acceptable adolescent health clinic is needed, where it meets the expectation of the adolescents. Next, even for this girl, even in the POXO Act also, we tell if the girl comes, we can give the emergency contraceptive pills, even for adolescents. There is no restrictions. You can inform police and you can file whatever it is, but the needed treatment should be given. So appropriate adolescent health, needed adolescent health clinic should be appropriate. The required care is provided and unnecessary harmful practices are avoided. If we don't give the easy pills, what will happen? Sometimes if she is going to become pregnant, she is already afraid with the parents and the teachers, and she will go to the unqualified persons and may end up with the complications. So appropriate is needed. Next, again, the girl, always we see the failures. The adolescents, they are not able to accept the failures. Whether they get the low marks or whether they get the love failure, whatever it is, they need help. Where to get the help? So adolescent health clinics should be effective and they should talk on the positive changes. See, if she is not going to get the good marks, means what is there? Next exam, she can have the good marks. Again, the love failure, previously only love failure and all very, very sensitive. Nowadays, it is not like that. One failure, next failure, till marriage, they can go on continuing that. So the positive change, positive attitude is needed. That should be given in the adolescent health clinic. Then again, she is having very tense. What to do? I told you, know, what are all the methods? Now she is having abortion also, but she is living with a boyfriend. What to do? But she is not able to tell anyone. So in that cases, we have to talk to them about even the contraceptions also. So comprehensive care provision should be given by the adolescent health clinic. That is needed. So care provision covers promotive, preventive, and curative aspects. So if when an unmarried girl comes with, means if she is very afraid with the parents and teachers, it is the need of the adolescent health clinic which can satisfy all the things. So this adolescent health clinic should promote the health promotions and disease prevention, diagnosis and treatment, and then rehabilitation. Rehabilitation is nothing. If the girl is having the pregnancy, means we have to talk about the comprehensive abortion care. Where it is present nowadays, the adolescent health clinic is present in all primary health centers. The girls cannot come daily, so you can have a particular time, Saturday or whichever time is convenient for the adolescents. And even the headquarters hospitals and the medical colleges, they have the adolescent health clinics. This is with the government, with the private, all doctors can have the adolescent clinic, and they should have a particular time and particular day. That will be convenient for the adolescents regular. And they can have about all the counseling programs, posters, banners, pamphlets, audio-visual materials, which will be useful for the adolescents. And also the outreach services by the counselor from the health clinic. The counselors, they also go for the outreach services, not only the counselor. See, I think Dr. Girish is always near Yavatmal, all schools are covered with the counseling, I think. Not only in Yavatmal, throughout Maharashtra. So I'm expecting Girish to Chennai once this COVID problem and everything is settled. So why the health clinic is needed? It is to monitor growth and development of the adolescents and to update them about the knowledges. See, for the menstrual problems, we are having the menstrual cups also. If the adolescent girls are comfortable with the cups and already they are using, we can tell about that also. Usually we advise for married women only. But if they are already using, means there is no harm in continuing it. So why it is needed? Reducing the obesity risk and improving the healthy food options and exercise, physical education and the tobacco use and helping children and adolescents from free from the chronic conditions. And though we need about the adolescents, these are all the barriers with the adolescents. Myths and misconceptions, where to go, and the lack of knowledge, they don't know where to get it, and they are not able to go to the clinic where the facility is available, and whether the privacy is present. This and all, they are very scared. That has to be, these barriers has to be broken. Then only they will come to the adolescent clinic. And if they go to the routine clinic, means they have to wait. You see some busy practitioner with the gynecology. If the adolescent girl is coming in, she has to wait in the clinic. Next day, she may be having the exam. So that is also, she is very afraid. And transport, as I mentioned, and the judgmental. Some doctors may accept the adolescent unmarried pregnancy and some may scold. These are all the barriers with the adolescent, and this has to be cleared. So of all this, now we have talked about the need of the adolescent health clinic. A few points about 5 to 6 slides, I think. What is to be done with the counseling? This is always, we know, we have to talk about the nutrition. That rather than talking, you can have posters like this. What are all the food needed and what are all the iron-rich foods? These posters, and you can't have to tell them, because the anemia is corrected in the adolescent. 12 grams, 12 gram of hemoglobin should be present in the age of 12. And it will be a cause of directly or indirectly maternal mortality in future. And this is the government projects, that is folic acid tablets given, deworming tablets given. These are all counseled. And exercise, now the adolescents are mostly with the laptop and sensor. They don't have outdoor activities. That has to be counseled. Swimming, sit-ups, whatever, simple exercise. Whichever is possible, that has to be given 30 minutes per day. Or taking the upstairs rather than avoiding the escalators and lifts. Because obesity, it will produce all problems. Now you heard from Dr. Durusha Madam about the PCOS. The obesity is most cause for PCOS, which in future goes for, when she becomes pregnant, gestational diabetes, and nearing menopause, she goes for metabolic disorders. So that counseling, again, mental health, stress, whatever stress already I have told, that has to be counseled. Whenever a girl comes to the OP, ask them counsel them with about the history, educations, and what is the diet, and about the friends, and what is the activity she is doing. Everything should be covered, and she should advise them even the simple yoga exercises, which will be free from stress. Then the menstrual hygiene, how the ovulation occurs, how the pregnancy happens, and what are all the hygiene methods has to be followed, whether it can be a cloth or diaper or menstrual cup, whichever is comfortable, that has to be advised. Sexual health, previously we used to tell safe touch and unsafe touch. Now, only thing I want to tell is take pleasure and pride in saying no. Never say yes when you want to say no. This is the mantra to be told to the adolescents. For girls, this is a method. And for the boys, no means no. All are very well know about what are all the meanings of no. The sexual abuse. See, if a girl is affected with the sexual abuse, means she is not able to tell the same thing to the mother. See, if a girl is living with the stepfather and the original mother, if the father is behaving something irrelevant, means she cannot tell her mother, because finance will be affected. Most of the time, the sexual abuses by the known person. So these are all the things that will be dealt with the adolescent health clinic. So first we should get the confidence from the adolescents. Then only they will come out with the problems, and they should be aware of the POXO Act, whether the girl or the boy. The girl, she can report to the clinic, and the boys, they are punishable. It will not take more time. Within 6 or they have the local judgment, and within 6 months, the punishment will be given. The contraceptive options should be given to the adolescents. That is, so educate the girls, avoid the early marriage, so that such that they can be free from teenage pregnancy, and then the abortions. As I told, unsafe abortion. Nowadays, it is respectful abortion care. Next, avoid the teenage pregnancy and tell them what are all the complications possible with the teenage pregnancy. Then the media. This is the way the adolescents are always. This will hinder with the academic performance and the health problem also, and it has also to be counseled. And about the rubella vaccine and HPV vaccine. Now we have the nanovalent. So if we counsel, we can have a future good adolescents, and the beautiful adolescents can be heard. So what are all the benchmark of adolescent health clinic? infrastructure. It should be attractive, clean, bright, and colorful, and easily accessible to the adolescents. And they should be aware of the clinic and what are all the things they can get from the clinic. And it should be maintained privacy and confidentiality. If you have an original clinic also, have a separate room, which the others, even the parents and the other patients cannot see. So that you can have alternate days or weekly once, whatever it is. So that is the benchmark. This is the studies which was elicited from the adolescents, what they feel about the clinics. Study A tells that some girls feel that there is no privacy, and study C tells that privacy is not there and they have to stand for long queues. So how it has to be fulfilled? Identify the problem of the adolescent, focus the problems, listen to them, always listen to the adolescent. Generate a solution, evaluate the solution, put the idea into practice, and evaluate the outcome. So this is the skills. The adolescent should be told, know your values, draw up the plan for your life, develop yourself, have a role model. Always the role model should be a good person. Even the father or the mother, most of the time for the children, role model is the parents. Make decision, be assertive, learn a sport. Parents should spend time with the adolescents. This is the 10 course of life we can tell. Decision making, problem solving, coping with self, coping with emotion, communication. That is very, very important. These are all the things should be dealt with the adolescent health. So the adolescent health clinic should be at a right place, at right price. Sometimes it should be free. If you are going to ask a lot of money, means they may not be able to give. Preferably free in certain conditions. And right style to be acceptable to young people. Otherwise, this will be the end of the adolescence. So thank you very much. Once again, I thank Dr. Girish and the societies for giving me an opportunity. Thank you.
Thank you so much, ma'am. Am I audible to all?
Yes, Dr. Nandini.
Yes. Thank you so much, ma'am. Good morning, everyone. Warm regards from myself, Dr. Nandini Bhagat, representing Hingoli team as its president. Today, I am so much humbled and honored to be part of this useful and informative webinar. I'm thankful to Dr. Girish Mane because of his support and good wishes. I am here with you all today. I'm very much thankful to Dr. Vrushali Mane too, and the team of Yavatmal. Coming to our topic of today, Dr. Samantha Kumari ma'am has so much clearly explained each and every point in so much in detail that I don't think that there is anything else left behind and anyone has any doubt about it. Not only we, the faculty, but also the audience will be benefited from madam's lecture. And I must say that I would request to the Dr. Shanta Kumari ma'am, our president Fogsi, and all the concerned seniors that we should start a revolutionary step in the adolescent by starting a adolescent clinic in our hospitals along with the obstetric and the gynec OPD. Because if we guide this adolescent group, as madam has told that they have the 20.9% of the population in India has largest one having this adolescent group, and which are the building block of our country's future. So to guide them and to avoid them unnecessarily going to the quacks and any other unqualified person, we should start an adolescent clinic, and it is a demand of time and to save our nation and to save our kids' future generation. It is needed. I'm very much thankful to our Yavatmal team by giving me this opportunity and chairing your session, ma'am. It is just an honor for me. And I'm very much again thankful to all the seniors and all the team members of Pusat Society, Yavatmal Society, and I represent on behalf of my Hingoli team, very much thankful for making us a part of such a useful webinar. Thank you so much, ma'am, for enriching and enlightening our knowledge. Thank you so much.
Girish, only 1 minute. Thanks to Dr. Ajay Mane, who is the coordinator. First, I forgot Dr. Ajay. Ajay, thank you and all the best.
Can I?
Thank you, Sampat madam. Great talk as usual. Thank you very much.
Madam, I just want just one small my experience and comment. Rightly, the need of the adolescent clinic is there, and it has been in in suggestion quite a number of years. But infrastructure wise, and there are so many issues, so that needs to be tackled because of the staff issue and the time issue. So we can incorporate into our medical college with a separate room, or if it all in a general OPD, what I do is like I just take that adolescent girl and mother into a separate room that is there, and I can start doing. And secondly, what we have done at a medical college, we have started integrated teaching for UGs and PGs also. So they also have the idea of the confidentiality and non-judgmental attitude, because that is to be imbibed right from their UG years and the PG years, so that they, when they are practitioners, when they come into the practice, they are with the idea of non-judgmental attitude and confidentiality. Thank you so much. Yes.
Thank you
madam.
very much. Yeah,
One
Supriya
word,
madam,
sir.
please.
Yeah, so it was really honored to chair your session. Your talks are always crisp and clear, madam. You give correct and clear messages, and very in brief you tell what to do and what not to. So thank you very much for the talk, brilliant talk. And I do counseling to all the adolescents who come for PCOs. Looking at them, we know, and it really helps them. They are worried about their looks and everything. So counseling is a real important part of our practice, madam. So thank you, rightly said. And Girish sir, thank you once again. Dr. Vaishali, thank you very much. And what was lovely chairing the session with Dr. Nandini. She was also wonderfully summed up. Thank you very much.
So loudly pair, Dr. Vaishali and Dr. Girish.
Thank you, madam.
Yes.
Yeah, and I'm feeling very proud to tell everybody. Actually, I'm telling this last 3 years that the person who is really mentor for me in this adolescent field of adolescent health is Dr. Sampat Kumari. Thank you very much, madam. And we are together since so many years. And definitely, I'll be working under you when you'll be vice president of Fogsi. I may not be. I'm in part of the Fogsi. I'm an office bearer of the Fogsi, but definitely I am there you for adolescent health. So now coming to the last and the fourth and very important session of today's CME, which will be chaired by Dr. Gayatri Rathod, who is president of Pusat Society, and Dr. Priti Kabra. So yeah, Dr. Gayatri Rathod, she is president of Pusat OBGY Society. She did her MBBS from IGMC Nagpur and her DGO from GMC Nagpur. She is director of Shri Seva Hospital Pusat, past secretary and vice president of Pusat OBGY Society. She is MMC observer. She is member of Family Welfare Committee of Fogsi since 1990 to 21. And she has been member of High Risk Pregnancy Committee of Amogs and member of Preventive Oncology Committee Fogsi 2021 to 23. And she has done a lot of activities for Pusat Society. Actually, Pusat Society is very small society, and unfortunately they got separated when I was president of YOGS. So this is really little bit worryful for me. But I welcome Dr. Gayatri Rathod madam, and thank you very much for gracing this occasion. Can I have CV of Dr. Priti Kabra? Yeah, Dr. Priti Kabra is past president of Yavatmal OBGY Society. And congratulations, Priti, for grabbing Fogsi award in your tenure. We had a lot of activities during Priti's tenure, but unfortunately, we couldn't do the YogsCon because of the Omicron, because of this pandemic. And Priti has done a lot of work for YOGS, and she has taken YOGS to some different heights. Thank you very much for gracing this occasion. Now over to you, both the chairpersons.
Thank you, Girish sir, for your kind words. Good morning, one and all. At the outset, I want to thank Dr. Brushali and Dr. Girish sir for including our society in this prestigious webinar. It's my pleasure to be associated with Hingoli and Yavatmal Society. It's my honor to read the CV of Dr. Asha Rao madam. She is the speaker for this eminent speaker for this topic. CV, please. Sir, CV. At present, madam is the chairperson of Endometriosis Committee, Fogsi 2020-22. She has experience of 25 years in ART. Madam is director of Rao Hospital and Care, Coimbatore. She is director for past doctoral fellowship program in reproductive medicine and endogynecology, and is affiliated to Tamil Nadu and Dr. MGR Medical University, Chennai. She has been the past president, Coimbatore OBGY Society, 2017 to 19 and 93 to 94. She has been the organizing chairperson, Endo Insight, 2021 International Endometriosis E-Congress with Fogsi and SEUD. Organizing chairperson, UA Fogsi, South Zone, 2019 at Coimbatore. She has been the organizing chairperson, IAGE Star Endogyne Conclave 2019 at Coimbatore. Organizing chairperson for the 8th National ISAR Conference in 2021. Gold medal from President of India and from University.
Thank you, Dr.
So I welcome Dr. Asha Rao Madam for a talk. Thank you.
Thank you, Dr. Gayatri, for those kind words. And at the outset, let me thank the organizers, Dr. Vaishali, Dr. Girish Mane, and the convener, Dr. Ajay Mane, for having given me this invite here to be here today and talk on my favorite topic of adolescent endometriosis. As all of us know, adolescent endometriosis is a disease which is more than 150 years old, yet we have so many difficulties in diagnosis and disputes in management. It is the presence of endometrial mucosa in abnormal locations other than uterine cavity. It can be seen in adolescent age group, reproductive age group, and perimenopausal age group also, with no symptoms or severe symptoms. Can you see my slides? Yeah. Are you able to see my slides?
Yes, madam. Very clear.
Okay. And it's a disease of theories, and the most important one being the theory of retrograde menstruation by Sampson. But it's not clear why some people get endometriosis, some people do not get endometriosis. And it continues to be an enigma and a challenging disease. And it is full of dilemmas: diagnostic dilemma, debilitating disease, progressive disease, disease with no cure, and history of multiple operations. When endometriosis appears during adolescence, there is likelihood that disease will progress if left untreated. It can produce adverse effects that go beyond pain and include infertility. Early identification of the disease is very important for slowing or preventing progression. I'm very happy that Dr. Girish has included this topic today because it's a very, very important topic. About 3 to 5% of adolescents seem to be suffering from endometriosis. Earlier, the disease versus the presentation. 2/3 of the adults with endometriosis claim that their symptoms started as teenagers. Young girls with chronic pelvic pain not responding to NSAIDs and oral contraceptives, we may see 70 to 80% have endometriosis. According to Goldstein et al., 47% of prevalence of endometriosis was seen in adolescent females with chronic pelvic pain who underwent laparoscopy. It has been identified in premenarchal girls who have started puberty and also have some breast development. That means at a very early stage, also people have seen endometriosis. And if there is an outflow tract obstruction, they also have a higher chance of getting endometriosis at a young age. And the children with the neonatal bleeding also could have adolescent endometriosis. Spontaneous resolution of endometriosis after release of outflow tract obstruction has been documented. And at what stage do we see endometriosis in these adolescent girls? Earlier, we thought it was basically in stage 1 and 2, according to Loeffler and Jensen. But later, researchers have shown that much higher proportion of young girls have advanced endometriosis. All stages of endometriosis, including deep endometriosis and ovarian endometrioma, are found in adolescent endometriosis. Condition is not limited to early forms only. This is very important. And risk factors we have discussed already: menarche at less than 14 years, family history, outflow tract obstruction, early onset of chronic pelvic pain, neonatal vaginal bleeding, and it can affect any of these sites: ovary, peritoneum, pouch of Douglas, bowel, ureter, bladder, and the 7 Ds of symptoms of endometriosis. There is dysmenorrhea, dysuria, dyschezia, dyspareunia if they're sexually active, DUB or AUB, and diffuse abdominal pain. Both cyclic and acyclical pain are seen in about 63% of patients. Only acyclical pain is seen in about 28%. Cyclic pain typically is seen only 9%. You may see gastrointestinal pain in about 34%. Urinary symptoms and irregular menstruation also could be one of the features. And there seems to be a tremendous delay of 9.28 years between the time of presentation to definitive diagnosis. And they are seen by at least 4.2 doctors, because we always have dilemmas. When a young girl comes to you, friend's daughter, she says, I have pain during menses. I have dull pain throughout the month. You think that the youngster is just conscious, she's fussing too much. We tell them, okay, do not take painkillers, take a hot water fermentation. And the family friends will tell her, do not see doctors, they'll put you on unnecessary medications. And when you go to the doctor, the family doctor also says, okay, ma, take one tablet, take a painkiller, you'll be all right. So this sort of, because for a proper diagnosis, we always did a laparoscopy, and we hesitate to do a laparoscopy on these young children. So because of these dilemmas, there is a delay in diagnosis. So today, the change in diagnosis from surgical diagnosis to clinical diagnosis makes life easier for the doctors and patients. If you need not do laparoscopy for everybody, unless it is peritoneal endometriosis, which cannot be seen by ultrasound, most of the other forms of endometriosis can be seen by ultrasound. Particularly, you should listen to the patient, see what type of pain they have, do a clinical examination. Pain resistant to medical therapy should raise the suspicion of adolescent endometriosis. And ask them to keep a pain diary. Physical examination may not show you the nodules in the pouch of Douglas like an adult. You may have to do a cotton tip swab to evaluate for the presence of transverse vaginal septum or agenesis of lower vagina. Look for risk factors, family history. And biomarkers may not be of any use. They are not of any use. Ultrasound helps you to differentiate the other problems like ovarian torsion, hemorrhage, renal problem, PID can be differentiated by ultrasound. And if there is an endometrioma, you can definitely diagnose endometriosis. And in sexually active girls, you can definitely do a vaginal ultrasound and look for deep nodules or adherent ovaries. If ultrasound is not helping you, then you can do MRI. But most often we are happy doing ultrasound and rule out other causes of chronic pelvic pain. As I said already, biomarkers, a lot of research is going on, but some more research has to happen because before we say that something is useful. Follistatin may be useful, say 125 only for follow-up. So early diagnosis and treatment is very important to slow down the disease progression and decrease the long-term side effects of chronic pelvic pain, DIE, infertility, and psychological issues. And it can improve the quality of life of these girls, because otherwise every time their periods come, they will be telling us, doctor, I'm getting my periods, will I be able to write the exam? Because some of them faint with pain. Some of them do not go to school for 2 to 3 days. School absenteeism seems to be one of the common problems because of adolescent endometriosis. So today, the guidelines have given us the right to treat empirically, avoiding surgery, according to the ESHRE guidelines and also World Endometriosis Society guidelines. You need not go in for surgical diagnosis or histopathology. You can treat them empirically, avoiding surgery. And you have to counsel the girl and her parents. Their symptoms are presumed due to endometriosis. It's a lifelong disease and needs lifelong planning and management. Surgery is to be avoided just to diagnose the endometriosis, because they may ask a doctor, how do you know it is endometriosis? Do not get into the trap and do not jump on them to do a surgery or a laparoscopy just to diagnose. You can treat them empirically for 60 days with analgesics, combined oral contraceptives, progestogens, or Dynogest. You may get a therapy, it's a therapeutic trial. If there is relief from pain, you can think that it is most often endometriosis. And this is a flow chart which shows that history, physical examination, imaging. If you suspect endometriosis by these methods, give cyclic hormonal therapy with NSAID. If pain persists unbearable, then one should definitely go in for laparoscopy. Do not hesitate to do a laparoscopy. Otherwise, the patient may go into advanced stages. And once you diagnose, if the girl child is less than 16 years, you can give hormone therapy, that is combined oral contraceptives. You can give continuous, which is accepted today. And if somebody is more than 16 years and there is no relief by COC or Dynogest, you can give GnRH agonist with add-back therapy to avoid bone loss. And after some time, you can again switch back to milder medications like Dynogest or COC. The first line of medication is combined oral contraceptives or oral progestins. According to the HRA guidelines 2022, there is no difference with either of the medication. The second line is GnRH agonist or Mirena intrauterine device. In patients who are not willing for COC, you may have to help them with the NSAID. Combined OCP give good symptomatic relief, but it is possible that sometimes endometriosis may progress while the symptoms are masked. This is one of the anxieties. So today the preferred drug slowly seems to be oral progesterone. It is weighing towards oral progesterone. Medroxyprogesterone can be tried, but the favorite today is Dynogest. According to Chaperon and Casper et al., you can see that estrogens in combined oral contraceptives may stimulate disease progression. While the symptoms may subside, there is possibility that endometriosis may progress or deep infiltrative endometriosis also may progress. This is one of the fears why slowly the scientists are favoring progestins. Because progestins cause residualization and atrophy of lesions, inhibition of matrix metalloproteinases, anti-angiogenic effects, anti-inflammatory effect, immunomodulatory effect. So they seem to be very, very good for managing endometriosis. And Dynogest, which is a 4th generation progesterone, seems to be very good for endometriosis. It's a FDA approved drug. It can be safely offered to adolescents, suppressing estradiol production and preventing the growth of endometrium. It has anti-estrogenic, gestogenic properties and strong anti-androgenic properties also. Very, very minimal bone mineral density, only 1% in the first year, and later it seems to be getting adjusted. To decrease the pelvic pain, it is very, very good drug. And even after stopping it, the good effect can last for 24 weeks. If you lose Dynogest for about 6 months, there seems to be a very good reduction in the size of the lesions. And according to this Visado study, which is a fantastic study in the adolescent groups of 12 to 18 years, it's a multicentric study in 21 centers in Europe, in 6 European countries. It concluded that Dynogest can be safely offered to adolescents. It can be used for a period of beyond 5 years. And there seems to be immediate return of fertility when they want it. Cost effective in comparison with GnRH analogs. Of course, combined oral contraceptive pills are definitely cheaper than Dynogest. So one has to always weigh the risk and benefit of both the drugs when you use them. There is no reduction of bone mineral density, no hot flashes, and good relief of pain. It seems to be a wonderful molecule. And according to the WIPO study, which was done in the adults, of course, Dynogest can be used for a period of almost 7 years with very, very minimal or no side effects, which is very impressive. Of course, there can be failure of therapy if the progesterone alpha or beta are absent. Medical therapy can fail. And the second line of medication today we can also say is aromatase, but it's used more in the perimenopausal age group rather than, some more studies have to happen, but seems to be very good. 1 milligram anastrozole per day plus progesterone can be used for 6 months. Letrozole 2.5 milligram per day plus progesterone can be used. It is important to use progesterone because otherwise you can get follicular cysts, or letrozole can also produce profound hypoestrogenism. So to prevent bone loss, one has to add progesterone. It can also be given along with GnRH analogs. I'm very happy using it in adults where they have resistance to other medication. And GnRH therapy is very good relief in people with, say, DIE, chocolate cyst, severe pain. Sometimes you can use GnRH therapy initially, and later you can switch them over to progestins. And HRA allows empiric use of GnRH therapy to avoid diagnostic laparoscopy. Placebo-controlled RCT have confirmed the efficacy of this method. Do not use empirically before 18 years because there could be a problem of loss of bone mineral density. So ACOG endorses its use over 18 years, since most of the bone mass is accumulated by 18 years. You can use it for primary medical therapy or second line of therapy. Post-surgical excision to prevent recurrence. Never leave a patient without suppression after surgery. All the good work that you have done will be lost because recurrence will happen in 6 months to 2 to 5 years. So always follow it up with medication after surgery. GnRH can cause effective regression of lesion, but you always have to give add-back therapy and follow it up with BMD if you are using it for more than 1 year. Tibolone can sometimes use for add-back therapy. LNG IUAs can be used in sexually active adolescents as second line of management. We always hesitate to do that, but sometimes when nothing works, LNG IUA seems to be good. It can cause regression of lesions and gives good relief from pain, and also regresses the adenomyoma or myoma's reversible action for return of fertility. It has been used by over 2 million women. It can be used along with GnRH analogs. It has got action, very, very good action, but the expulsion rate is about 5%. Ovarian endometrioma sometimes may not regress because ovulation may not be inhibited always. And RCT show non-inferiority to leuprolide acetate. Danazol was a wonderful medication. We enjoyed using Danazol on those yesteryears in the 80s. But because of the androgenic side effects, this wonderful drug lost its popularity. But today in Europe, they are trying, research is going on for vaginal Danazol. You can use the same oral tablet vaginally, or sexually active girls, you can also have intrauterine device of Danazol, which can be used for about 6 months, gives very good pain relief. And there are no androgenic side effects because the serum testosterone levels are very low. Petraglia et al. From Italy, they are doing this study. Let us wait further for results. Vaginal rings are also available, but not in India. So when do we do laparoscopy? According to Chaperon, in year 2022, there is no role for diagnostic laparoscopy unless it's a girl who is suffering from pain in spite of medical management. So it should be considered in adolescents with chronic pelvic pain, if the empiric therapy fails, or if they're not willing for empiric therapy. Sometimes you may like to differentiate it from other PID, tuberculosis, etc. So if at all you do a laparoscopy, definitely do a biopsy. You may see flame-red lesions, clear red lesions, subtle lesions, peritoneal windows like this, vesicular lesions. And these are the lesions near the ureter, hemorrhagic endometriosis. This is the cortical endometrioma lesions on left ovary in a 15-year-old patient with stage 3 endometriosis. This is diffuse variable appearing endometriosis in the Pouch Douglas and also in the left paraureteral region. Hemorrhagic endometrious lesions on the broad ligament. So if the problems continue in spite of good medication, one may have to do surgery, laparoscopy sometimes. It should always be a laparoscopic surgery. Avoid laparotomy as much as possible and see that the incision is having a cosmetic effect, lower border of umbilicus. First surgery should be done by an experienced surgeon. I would say every surgery should be done by an experienced surgeon. We have no right to experiment on the patients. And adolescent patients can have atypical findings which you may miss. And one has to be very careful in saving the ovarian tissue and do not lead them to exhaustion of ovaries or loss of ovary. And all lesions need to be ablated. And staging the disease is very important for future reference.
Thank you so much.
Yeah. So endometrium should be considered in adolescents presenting with bilateral complex ovarian mass regardless of their size. Post-operative long-term maintenance therapy with Dynogest or OCP is required to suppress the chance of recurrence. Lifestyle modifications, exercise, diet, psychotherapy, antidepressants, acupressure, various reflexology, various methods are being tried for relief of pain. So this is one interesting case. This is Miss D. Now she's 29 years. She complained of she has severe dysmenorrhea. According to her history, she started pain in 2003 when she was 10 years. When she attained menarche, she had heavy menstrual bleeding. And she was on hemostatic drugs. That time her pain was less. By the time she was 19 years, she had heavy menstrual bleeding with dysmenorrhea, dysuria, and left ovarian cyst 6 into 4.4 centimeter. And she was given cyclic novilon for 4 years. She came from a remote corner of Tamil Nadu. The bleeding decreased, but the pain persisted with OCP. At 23 years, OCP was stopped because the pain and bleeding had increased. And later, again, the symptoms came back. At 27 years, again, she has endometrioma of the ovary. Dynogest started. She came to us at 28 years, 1 year after Dynogest. She was referred to us for surgical management. And this is the picture that we saw. And adenomyosis, focal adenomyosis 4 centimeter. And chocolate cyst in the ovary. So it was very tempting. But how can you do a surgical management in this case? Because you can never relieve her from the adenomyosis. And even if you remove this chocolate cyst, the recurrence will be very prompt. So we treated her with a combination. We gave her a GnRH analog. She's 28 years now. And her history is that of 18 years. She started at the age of 10. So we gave her a GnRH depot initially for 3 months. And later we have followed her up with the aromatase inhibitors. And slowly we have coaxed her. And last month we have inserted a Mirena intrauterine device. And we told her about early marriage. She said, ma'am, my elder sister is yet to be married. She's 30 years. I'm 28. When will I get married? I do not know. So she has now agreed for Mirena. She's now on a combination of Mirena and aromatase. And later we'll stop the aromatase once she's better. Her pain and bleeding both are under control now. So as much as possible, dear friends, let us not do any surgery on these young women. According to Chaperon, today what you should do is non-surgical diagnosis of the old trend was diagnose endometriosis, immediate first surgery, post-operative medical treatment, stop it after some time, repetitive surgeries, and ART at the end of it. But today what we have to do is non-surgical diagnosis, long-term medical treatment, avoid surgery. If necessary, occasionally you can do a single complete surgery followed by ART if needed when fertility is wanted. Follow it up again with long-term medical management, avoiding surgery. So the take-home message is early diagnosis is very, very important in these young women, young girls, to prevent the progression of the disease. A presumptive diagnosis of endometriosis based on history and clinical assessment imaging is good enough. Diagnostic laparoscopy, once considered the gold standard to diagnose endometriosis, is no longer considered so. It's only a therapeutic measure. Long-term follow-up is a must to prevent recurrence. So just because you can't see it does not mean it does not exist. Living with an invisible illness. So kindly help these suffering women to cope up with the disease. And thank you all for a patient hearing. And thank you, Dr. Girish Mane and Ajay Mane once again, and Vaishali, of course. Thank you.
Thank you, madam. Thank you very much for the great talk, as usual.
Thank you, Dr. Ajay Mane.
Yeah, and congratulations to you for your son.
Oh, thank you. Thank you so much. Thanks to all of you for the support. All of you have been very supportive to him. And thank you so much. And wish you all the best in your forthcoming election.
Yes, ma'am. Thank you. Thank you very much.
Yeah.
Dr. Priti. Dr. Priti, unmute yourself.
Thank you, Asha ma'am, for the wonderful simplified talk. You have already mentioned that it is a disease with dilemma and no definite cure. Really true, ma'am. It is truly quoted that endometriosis is not just a disease of reproductive tract, but one which can potentially cause severe chronic symptoms throughout the entire body, including incapacitating pain, severe chronic fatigue, infertility, immune and endocrine dysfunctions, and it damages the multiple organ tissues like bowel, bladder, uterus, muscle, musculoskeletal structures, nerves, ligaments, and so on. Thank you so much, ma'am, with the proper take-home messages and very nice talk and in a simplified manner. And thank you, Rishali, for making us the part of this webinar. Thank you, Mane sir, for appreciating our work. Thank you, Ajay sir. Thank you, all the organizers.
Thank you.
Yeah, Asha madam, nowadays in India, because the Dynogest actually it's very costly molecule. So under the banner of for this contraceptive pill and by adding estrogen along with the Dynogest, many companies they are selling this Dynogest along with the estrogen in a very low price. So what is the clear message from your side to all the delegates whether there is any difference between using plain Dynogest and Dynogest along with the estrogen? I mean, how will you compare it?
Yeah, I think still I'm not very comfortable using this Dynogest along with the estrogen.
Correct.
Because according to the studies also, the regression of lesions is much better if you use Dynogest alone. This is according to papers. Correct. So I would always prefer a plain Dynogest to combination of estrogen and Dynogest. If you have to use estrogen and Dynogest, may as well use the OCP like you said.
Correct. Correct.
No, which is much cheaper.
Right. And we are actually trying to get the anti-estrogenic effect of Dynogest. So it will never be wise decision to prescribe estrogen along with the Dynogest. So this is the take-home message for all the delegates that instead of using the combination of estrogen and Dynogest, even though it's cheaper, it is definitely wise to use only Dynogest. There are so many alternatives for the Dynogest companies which are providing it in a cheaper way. So I think there are there any questions from hello? Any question? So thank you very much, Asha madam. Thank you very much, Dr. Preeti and Dr. Gayatri for the wonderful session. And I personally extend my sincere thanks to all the speakers, Dr. Asha madam, Dr. Sampath madam, Dr. Guru madam, and Dr. Lakshmi madam, all the chairperson, all the delegates. Thank you very much. Now over to you, Kiran. Kiran Durve is clinical secretary to YOGS. So I request Kiran Durve for the vote of thanks.
Thank you, Asha madam, for accepting our invitation and enlightening us with this topic. Thank you so much, ma'am.
Thank you.
Kiran.
Yes, sir. Am I audible, sir?
Yes, please go ahead.
Good morning, one and all. At the outset, I would like to say thanks to President and Secretary of YOGS, Dr. Rushali Mane madam and Yogita Zopate, along with Hingoli and Busad OBGY Society. First of all, would like to say thanks to Dr. Girish Mane sir, who is the chairperson of Fogsi Adolescent Health Committee, and Dr. Supriya Avari madam, who is the chairperson of Amogs Adolescent Health Committee. Thank you so much, Dr. Ajay Mane sir, who is the convener. And my heartfelt thanks to Dr. Basab Mukherjee sir, who is the vice president of Fogsi, Rajendra Singh Pardesi sir, who is the vice president of Amogs. And I am thankful to all the respected speaker, Dr. Lakshmi Srikhande ma'am, Dr. Duru Shah ma'am, Dr. Sampath Kumari madam, Dr. Asha Rao ma'am, and all the esteemed chairpersons, Dr. Rajal Thakkar madam, Dr. Lata Agrawal madam, Dr. Sheetal Agrawal madam, Dr. Kiran Kurkoti sir, Dr. Supriya Jaiswal madam, Dr. Nandini Vaidya madam, Dr. Gayatri Rathod madam, and Dr. Preeti Kabra madam. And once again, special thanks to our dear delegates for sparing their time on this Sunday morning. And last but not least, thanks to our academic partner, Corona Remedies, for providing such a wonderful platform. And one small announcement is there. On evening of 12th of March, we are conducting a webinar on contraceptives. So please be there with the same enthusiasm. So thank you once again, one and all. And here I conclude the session.
Thank you, dear Kiran, for this vote of thanks.
Thank you and bye-bye.
Bye, ma'am.
Bye.
Thank you, Girish sir, Shali ma'am. Bye and thank you.
Thank
Ajay sir,
you.
thank you.
Thank you, Supriya madam. And
Thank you, Dr. Girish.
yes, thank you, Girish and Vrishali. Yes, everything is done by Girish and Vrishali and all the president and secretaries of Pusad and Yavatmal Obgy societies. Thank you very much.
Thank you and good to see you all. All the best and see you soon. Bye.
Thank you.
Indore.
Bye, ma'am.
We are meeting at Indore.
Yes, ma'am.
Yes.
Thanks a lot, Dr. Gayatri, Dr. Nandini. Thank you very much.
Thank you, sir.
Thank you, Nandini.
Bye.
Thank
you. Girish sir, going for a physical meet of ISOPAR.
When? Okay,
Just
you are
now
going
for a physical meeting at a place in Patna of ISOPAR.
Okay.
coordinator there,
Okay,
sir,
okay.
running there. Thank you so much once again, both of